The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, or good evening, and welcome to this webinar on the safety and efficacy of calcium vitamin D supplementation in older people with osteoporosis. I'm Dominique Pierrot, Science Manager at IOF, and I'm happy to moderate this webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing your questions into the question box of the GoToWebinar control panel. I will voice the questions to the speaker towards the end of this webinar. This being said, I'm happy to introduce for this inaugural Bonecast webinar our speaker, Professor Nicholas Harvey. Professor Harvey is Professor of Rheumatology and Clinical Epidemiology at the MRC Life Course Epidemiology Unit, University of Southampton in the UK. He is also Chair of the International Osteoporosis Foundation Committee of Scientific Advisors and is active in many national and international committees and societies. Professor Harvey, please, we are listening to your lecture.
Thank you very much, Dominique. And well, good morning, afternoon, evening to you all. And it's a great pleasure as the chair of the IOF CSA to give this inaugural presentation. And I thought what I would do is really focus mainly on the safety aspects of calcium and vitamin D supplementation. I'll start off with a few words about efficacy. But I think really the controversy in recent years has been around the safety. And this is an area where the devil is very much in the detail. And so I will try to just elucidate some of those details to give you the story and try to make sense of the work that's been done. And I think with really quite reassuring conclusions. So if we look at the efficacy story first, this is of course an area in which there are probably rather more meta-analyses of clinical trials of calcium and or vitamin D than there are trials themselves. And of course, depending upon which studies you include, which you exclude, and various criteria, you will get rather different flavors of outcome. And a good example of a patient level meta-analysis is that from Bo Abrahamson and co in the DIPART fracture study, which looked at 68,500 older individuals. And this, I think, really illustrates what I view as the take-home interpretation of the field and the literature as a whole, such that if you give calcium and vitamin D, there's a very modest benefit for all fractures, so here an 8% reduction, and for hip fractures, 17% reduction, but not really a signal for vitamin D alone. And this study included community-based and institution-based studies. And of course, going back to the classic Chapuis study in French residential homes, we see this effect on reduction of hip fracture and other non-vertebral fractures, you can see in the charts here, in around 3,000 older women supplemented with calcium and vitamin D. And overall, perhaps the evidence is rather more robust for institutional participants compared with community dwelling. And overall, the evidence is rather more robust for calcium and vitamin D compared with calcium alone. And I think the record study, which is a trial, community-based secondary fracture prevention as a sort of public health intervention to all those who've had a fracture, really demonstrated that calcium vitamin D as a routine intervention to try to prevent fracture is not as successful as targeting to those who may have higher risk of deficiencies in these nutrients. And so I haven't spent long on this section because I really want to focus on the safety aspects, but bringing it all together, I think the evidence suggests that calcium with vitamin D is rather best directed at those who are likely to be deficient in these nutrients, and that may well be those in institutional care, for example, or those with other reasons to be deficient in either. The evidence best supports the use of both together rather than vitamin D alone, and indeed rather than calcium alone, and there's fewer studies of calcium alone, and the results are not as convincing as they are for calcium and D together. And of course, most licensed anti-osteoporosis therapies are licensed in the context of calcium vitamin D repletion, and to achieve this supplementation is likely to be appropriate. And of course, assessing calcium intake is potentially tricky in the clinic, and I draw your attention to the IOF calculator, which may be helpful in this regard. And the intake for somebody with osteoporosis is usually recommended to be around 1,000 milligrams a day. So if we move towards the safety aspect now, and this is really the meat of the talk, I'll start first looking at gastrointestinal and renal effects, and it's really, up until the work from the New Zealand group in 2010 or so, that GI side effects and renal side effects were the main adverse effects associated with calcium supplementation particularly. And in the work from the WHI and synthesized in this Cochrane review, that's about a 17% increased risk of renal stones with calcium vitamin D supplementation, and that seems intuitively very reasonable given the additional calcium load filtered through the kidney. And of course, those of us who are in clinical practice and prescribe or recommend calcium supplements for our patients are well aware of the difficulty in tolerating these supplements experienced by many people. And so one of the issues, and I think an important issue in the interpretation of the safety data, is the capacity for calcium-induced, and this is much more calcium rather than vitamin D, because vitamin D by itself tends to be extremely well tolerated. But calcium supplements causing upper GI discomfort, for example, could easily cause events that are mistaken for myocardial infarction or angina, for example. And of course, that sort of misclassification is of key importance in the interpretation of the safety data. So as we, and this has been looked at by Joshua Lewis and his collaborators, and what he showed is that the GI side effects are more common with calcium supplementation, shown in this forest plot across these various randomized controlled trials. But he also looked at trials which had been included in the various Bolland meta-analyses and looked at the rates of self-reported and then adjudicated and then self-reported but non-verified events for myocardial infarction by calcium and placebo. And you can see that if you look at the percentages, self-reported, greater with calcium than placebo, so 3.6% versus 2.1%. But adjudicated, okay, it's higher, but it's not significant. And then you can see that the rates of self-reported but non-verified are indeed higher in the calcium than placebo groups. And so when you take calcium, there's a greater risk of GI adverse events. There's actually greater risk of hospitalization with GI adverse events. And there's a greater risk of having events that are actually due to irritation of the gut, misclassified as cardiac. And of course, that may contribute to some of the cardiovascular safety signals that have come to light. So I'll really try to focus now in some detail on the cardiovascular story. And as I suggested, until the work from Bolland et al. From the New Zealand group, the safety signals for cardiovascular outcomes with calcium and vitamin D were pretty reassuring. So in the Women's Health Initiative, so a very large randomized controlled trial of calcium and vitamin D versus placebo over a number of years of follow-up, we can see that the hazard ratio for MI coronary death was 1.04 completely non-significant, and for stroke 0.95. So again, and you can see that 95% confidence intervals. So really no safety signal or beneficial signal either way in WHI. And just bear that in mind when you look at some of the newer, the New Zealand interpretation and analyses based on WHI, that the WHI investigators have generally found no cardiovascular signal. So where did the story start? Well, in the Auckland calcium trial, this was reanalyzed in this post hoc analysis looking at safety outcomes by Mark Bolland and his colleagues and published in the BMJ in 2008. And what they found was that over the 60 months of follow-up, there was a greater rate of myocardial infarction in the intervention group, so the calcium group, compared with the placebo group in these older women. And the relative risks were 2.24, but with quite a wide confidence interval from 1.2 to 4.17, but statistically significant. However, it's interesting to note that rates of angina, as you can see here, appear to be rather less in the intervention group, and that was of borderline statistical significance. So it's difficult to conceive biologically of a mechanism that gives you myocardial infarctions but reduces your risk of angina. And I think that sort of mechanistic inconsistency is something to bear in mind as we move through these data. Various analyses were undertaken linked to the self-reported data, verified data, then further data bringing in from health records, and it's really only the self-reported data that suggested the differences in MI outcome. And it's worth looking at the baseline characteristics, and you can see that for various parameters such as LDL cholesterol, percentage of smokers, former smokers, blood pressure and hypertension and so forth, there were not always significant, but there were indicators of cardiovascular risk, which were generally more prevalent at baseline in the calcium group. So again, we need to bear that in mind in how we interpret these results. Of course, that finding generated a fair amount of publicity. And the next stage for the New Zealand group was a meta-analysis of several calcium studies. So this is calcium versus placebo, and that in total across all the calcium studies, there's around 6,000 or so women enrolled in the various studies, and probably about 50 or 60,000 enrolled in calcium and vitamin D studies. So that's another point worth bearing in mind, that the power to look at things in calcium studies and the reliability is much lower. But here, looking at the outcomes of myocardial infarction, stroke, and we have composite outcomes and risk of death, the following signals came through, such that for MI there was a 27% increased risk of not particularly robust statistical significance, p equals 0.038, no increased risk of stroke, no increased risk of death, and the composite outcome again was non-significant. But the one interesting observation here is that there was evidence of an interaction between the treatment and baseline dietary calcium intake for myocardial infarction only, and that the risk with the supplement was rather greater above the median than below the median. So you think that probably makes biological sense, that if you've got a higher baseline intake of calcium and then you give some more calcium, that maybe that pushes you up into a high risk of an adverse event. Bear that point in mind as we talk about the next stage of the analyses. So then, of course, the question was, well, what about vitamin D? Is that going to be protective? How's that going to sit with the calcium supplement? And so the next phase was a meta-analysis, again in the British Medical Journal, from the New Zealand group, looking at the Women's Health Initiative and subsequent and further studies using calcium and vitamin D in a meta-analysis. So the first phase of this was to undertake a secondary analysis of the WHI, Now, this is a very large randomized controlled trial in women, in postmenopausal women, of calcium and vitamin D versus placebo. The nuance here is that women were permitted, as part of the protocol, to take personal calcium and vitamin D supplements. And the Auckland group hypothesized very reasonably that the relationships between supplementation versus no supplementation might differ according to personal use of calcium. And bear in mind that in the calcium-only meta-analysis, it was those with a greater baseline use of calcium in which we saw the effect of adding calcium supplementation. And here, where the stratification is by no personal use or personal use of calcium and vitamin D supplements, you might expect to see a signal in the personal use of supplements part of the cohort. But actually you see the opposite. So overall, there are some rather modest differences by supplementation versus placebo. You can see for clinical myocardial infarction in the no personal use, a 22% increase, but borderline statistical significance. Not there in the any personal use, but there were interactions. And the issues here is that the rather greater magnitude, although still modest, effects appear to be in the no personal use. So rather the opposite of the interaction that we've seen in the calcium meta-analysis. And it's difficult to square that difference in sort of direction of interaction with a biological mechanism. And I think the other thing you'll notice about this table, if you look at it in detail, is that everything is of borderline significance, and some things actually appear protective. So, you know, for example, on the any personal use, we see clinical MI is a bit lower, although non-significant, but then clinical MI or stroke is lower, and again, nearing significance. And so across the board, there's some things which are a bit higher, some things which are a bit lower, and it doesn't necessarily give a coherent ischemic vascular mechanistic story that you might expect if there's a convincing biological mechanism. So putting this together, and that the WHI analysis rather contradicts the earlier study with the risk highest with the greatest dietary intake in the previous study, but there in the no personal supplements in WHI. When WHI was meta-analysed with other studies, either patient level or study level, again, there was a signal for myocardial infarction, but again of modest magnitude. The other nuances from this analysis were that there was an examination of dose effect, which was not convincing. And I think just to summarize this part of the presentation, all of these studies are very heterogeneous in their design. They're very heterogeneous in terms of the outcomes and outcome ascertainment. And bear in mind, MI or angina or stroke, none of these things were the primary outcomes of any of these studies. And they were collected in a variety of means and validated in a variety of different ways. And so we need to be a bit careful about the interpretation that's given to these findings. And you know, for what it's worth, there's a sort of methodological debate here about whether, you know, of course, in a randomized controlled trial setting, in a single trial, you don't tend to adjust safety outcomes for multiple testing because you have a prima non nocere approach to sort of safety first and looking for signals. But you know, you could argue in a meta-analysis post hoc, one might want to adjust for multiple testing, which of course would bring much of this out of contention. So, what about the WHI itself? This is the largest study, and the WHI investigators went back to look at all of this and looked at 5 years after the end of the intervention period. And really, there's just no signal at all for coronary heart disease outcomes. And that there was actually minimal difference for several outcomes at this stage, although some evidence reduction of vertebral fracture, but really no convincing signal there. And there was also a further analysis stratifying by use of personal supplements or not, and also by time on treatment. Now, you would think that for something where the putative mechanism is to do with increased atherosclerosis leading to ischemic heart disease, that you would see an increased risk as time goes on treatment. But actually you don't see that. And so here, what I've done is just summarize the hazard ratio for MI and then coronary heart disease by time, so less than 2 years, 2 to 5 years, or more than 5 years on treatment for the trial as a whole. So about 18,000 on placebo, 18,000 on treatment, and then for the 7,500 in each group who were not taking personal supplements. So that's the group that appeared to be at high risk in the meta-analysis of Bolland et al. And really we can see there's non-significant signals there at less than 2 years, but as you go on, no convincing evidence at all for any accumulating risk with either outcome with time. And the risk of MI in personal supplement users, you can see down here again, was near unity. So really findings that are not consistent with the Bolland analysis. And so where do we go from this rather confusing picture? Well, Joshua Lewison and his group took the very reasonable premise that we should be using only verified events, and I would completely agree with that given the heterogeneity across the studies. And he also decided that it would be sensible to look at women only. And of course, the reason for doing that is that actually there's not many men in these trials, and the power to derive any sensible conclusions relating purely to men is extremely limited. So he undertook a very comprehensive meta-analysis using only verified events in women, and that led to a really quite large sample sizes. And what he found is for sort of all cardiovascular events, there was really no signal at all. And there were various sensitivity analyses and sub-analyses. So with myocardial infarction as the outcome, you see you've got around 50,000 participants, no signal. Angina, acute coronary syndrome, no signal. Chronic coronary heart disease, no signal. And this was based on over 60,000 participants with, over almost 3,500 coronary heart disease events. Now, what we think is a similar analysis was undertaken by the New Zealand group, excluding self-reports. But again, they found a similar to their previous findings, about a 30% increased risk of MI with calcium and 26% increased risk with calcium and vitamin D. Those findings are published in a review article rather than the original paper, and it's not so certain as to which studies were included. So it's difficult to compare that directly with the Lewis analysis. But I think in terms of the sub-analyses, really there was no difference in terms of the no personal supplements group in WHI. The one thing that is worth looking at is that in the calcium alone group, where there were only 6,000 participants compared with 60,000 across calcium and vitamin D, although it was non-significant, there is this signal of calcium alone, around a 37% increase, but of course with the 95% CI crossing unity. But as I say, that's a subgroup and with a much smaller number of participants than with calcium and D. But it's just worth bearing that in mind. However, we're able to look at this in the UK Biobank cohort, and okay, this is observational, but we were able to comprehensively account for potential confounding factors. And looking at calcium alone or calcium and vitamin D or the combined supplements, there was very little evidence, in fact, really no evidence for an increased risk with any of these interventions in over 500,000 men and women aged 40 to 69 years at baseline. So fairly pretty reassuring findings. So in the second of the sets of learning points, there's clearly a clear evidence, and it seems intuitively and mechanistically reasonable, given what we know about the kidney, that calcium supplements might lead to the increased risk of renal stones. There's clear evidence for GI side effects, and of course, these may be mistaken for cardiovascular events. But I would say that the evidence for cardiovascular harm from calcium vitamin D supplements is very inconsistent and indeed very unconvincing, and that's particularly when given with vitamin D. So what about mortality? Well, I'll go straight on to learning point 3. There's no evidence of any effect on mortality. And I won't go into the details here because it's really rehearsing the same sorts of studies, but with mortality endpoints. But across various trials and cohorts, there's really no evidence. And of course, it may be simply that the effect size on MI, because of course not every MI is fatal, is not large enough. But it seems reasonable, given what we know, that if there were an effect on mortality, given the sort of sample sizes we have, that you would see some sort of signal, and there's nothing convincing there. So what about mechanisms? And I've kind of hinted as I've gone along that there's not a huge amount out there that convinces us that there is a mechanism by which calcium vitamin D supplements in normal physiology might lead to increased risks of ischemic heart disease, for example. And when you take a calcium supplement, there's certainly a transient slight increased rise in serum calcium and a slight decrease in PTH, but this is nowhere near big enough changes to affect the saturation of the calcium hydroxy and the calcium salts and precipitation onto tissues. And there's evidence that the development of coronary plaques and subsequent calcification is an active cellular molecular process. It is not dependent upon the calcium concentration in the plasma. And there's several lines of evidence which are reassuring. And just as as an example, you give teriparatide, there is potentially a slight transient rise in calcium, but there's absolutely no signal at all of any link with cardiovascular outcomes in that situation. And so in normal physiology, we just really have no convincing mechanisms linking calcium or calcium vitamin D supplementation with cardiovascular outcomes. Now, that's not to say that that's the same across the board in all physiology, and I think the example is chronic end-stage renal failure, and there we know that, of course, physiology is massively different. And there we do know that there's evidence that giving calcium supplements may increase cardiovascular risk, and that's a fact well known to renal physicians. And their mechanistic studies have demonstrated that if you take healthy vascular endothelium versus vascular endothelium in the context of a patient who has uremia, so an end-stage renal failure, then increasing the calcium concentration in your experimental setup, excuse me, will lead to increased calcification of plaques in the renal failure setting, but not in the normal physiology setting. So there is something different about renal failure here. And of course, there is a concern potentially in the very elderly where more modest levels of renal failure are quite common. But really that is not quantified, and we don't know the correct approach to that. And I think the evidence thus far suggests that it's really at those very severe levels of renal failure that where there might be concerns. So in terms of mechanistic studies in the bigger cohorts and trials, the way of looking at coronary artery calcification is through cardiac CT. And in the Women's Health Initiative, this has been done in a subset of around 750 women. And here, there was really no evidence, as you can see here, of a difference in levels of coronary vascular calcification by intervention versus placebo. And that was irrespective of baseline intake of calcium or vitamin D. And in more recent analysis of a calcium trial undertaken by Lewis and colleagues in around 1,500 women over 70 years, with aortic calcification as the outcome on lateral spine DXA, you can see that there's really no difference between placebo and the calcium groups at 5 years in terms of this vascular calcification outcome. And again, high sensitivity troponin is a marker of very low level myocardial damage, which serves as a good marker of things that are bad for your heart effectively. So sort of low level ischemic heart disease. And in the same study, there was just, again, no difference between the groups at 5 years. So putting all that together, just to emphasize that there really is no mechanistic evidence to support a causal relationship between calcium, vitamin D supplementation and cardiovascular disease in normal physiology. And that goes across sort of basic science, lessons from drug trials, and then the more mechanistic outcomes of cohorts. So all very reassuring. And to put all that together across the entire presentation, we can conclude that calcium with vitamin D supplementation appears to modestly reduce fracture risk. And probably on the whole, the evidence is best for institutionalized individuals and less good for just the routine supplementation of individuals. And of course, one should never view calcium vitamin D as therapy in itself, without considering more dedicated specific anti-osteoporosis treatments. But it seems very reasonable to target calcium vitamin D supplementation to those where deficiency is most likely, for example, those living in institutions. Evidence for harm is inconclusive in terms of cardiovascular endpoints. We certainly acknowledge the adverse GI events, the adverse renal events, but with all the considerations of the inconsistent ways of defining outcomes, the fact that these are post hoc, that they're safety outcomes not properly defined or validated, and the differences between the various analytical approaches and the meta-analyses, the inconsistency in relation to baseline intake, and the lack of a plausible mechanism. My own view is there's certainly not a convincing evidence base for cardiovascular harm with calcium and vitamin D supplementation together, or with vitamin D alone. And so these should be, so really the message, so the take-home message is that use calcium vitamin D supplementation together where they're needed to reverse an intake deficit or status deficit. Use them with anti-osteoporosis medications where you just don't think that people are replete. The potential is there to use vitamin D alone in people with a very good calcium intake. But I think, on the whole, although the evidence is certainly not conclusive for calcium alone, it's sensible to avoid the use of calcium supplements alone, both on the basis of efficacy and less convincingly with safety. But the message is really to use them together. So if you're having difficulty sleeping and you have a lot of time on your hands, then there's around 8,500 words written on this. which you can enjoy at your leisure from Osteoporosis International. And with that, I'll just thank very much the IOF for hosting this, and of course all our funders and supporters. It's my pleasure to finish there and to take questions, and hopefully I'll provide you some answers. Thank you.
Thank you very much, Professor Harvey, for your excellent talk and covering the efficacy and calcium vitamin D supplementation for reducing fracture risk. Thank you for summarizing the side effects of calcium supplementation and giving guidance for appropriate use of calcium vitamin D supplements in clinical practice, which I'm sure was appreciated by our audience. Now, I would like to move on to questions, as we have received a number of them during the presentation. So maybe the first one will be, do you have some standard doses of calcium and vitamin D for osteoporosis?
Yes, so I think there's a number of ways of supplementing, and of course, the standard sort of approach of the majority of the sort of standard calcium vitamin D licensed tablets out there. If you give a couple of them, you'd end up with along the lines of 1,000 milligrams of calcium and 800 units of vitamin D, and that seems a reasonable ballpark for the majority of individuals. There's rather more variation in approaches to vitamin D prescription, and the field has moved rather away from high bolus dosing, because we know, from Kerry Sanders' work and in the Australia and other studies that giving a very high dose, for example 500,000 units or 100,000 units at one go, may increase the risk of falls and fractures temporarily. It's not really understood why, but it seems to, and therefore moving to a more sort of physiological daily supplementation with vitamin D if you need to get levels up, and you could use a higher dose on a daily basis, up to sort of 3,000 or so units to replenish people, is often a good approach. And so yeah, there's flexibility, but I think one important point is that where there's if it's a medical indication rather than just somebody who's concerned and wants to take a supplement, then it's worth using licensed preparations which can be prescribed, because of course then you know exactly what you're getting. And if you use preparations that are made as supplements, then of course the regulations around those are less stringent, and there's more leeway on exactly what the dose is that you're getting.
Thank you. Another question related to calcium supplementation, like, does my patient need calcium supplementation as well as vitamin D supplementation, or can I just use vitamin D supplementation alone?
Yes, and that of course absolutely depends on your patient, and I think my own approach is that these are threshold nutrients. The sort of Bob Heaney approach is that probably once you've got enough, you don't need more. And so if you've got a patient who is drinking a pint of milk a day and loves cheese and eats brown bread and sardines with all the bones in, all that sort of stuff, then they're getting a lot of calcium in their diet. There's no point giving extra calcium with a supplement. And in that situation, it may be that just giving pure vitamin D by itself is the sensible option. And of course, it's much more difficult to get adequate vitamin D from the diet. And if you're in a part of the world where you don't get much sunshine, or you just don't go out much, or it's the winter or whatever, then you're not synthesizing much in the skin. So you may well need a vitamin D supplement to keep levels reasonable. And so yeah, I'd very much tailor it to the individual. And of course, assessing calcium in the diet is not that straightforward without the help of a calcium tool. But of course, that's available on the IOF website, and there's various approaches around.
And so thank you. And there are many attendees asking questions. if there is differences between calcium carbonate versus calcium citrates in terms of side effects?
Yeah, I think that's a really interesting question, and it's something that is not really well answered by the literature. I mean, it's certainly a story that has been made in the past, but I don't think with really very much evidence behind it. And of course, you can kind of look at the trials and see which was the particular sort of supplement used in that particular trial and try to make a story out of it. But I don't think there's a particularly convincing literature out there on which to base decisions about the sort of calcium supplement used, at least not in normal physiology. I mean, there are potentials, particularly with the use of phosphate containing supplements, you probably would want to avoid in renal failure, for example, but in normal physiology, there's really not a convincing story there.
Thank you. So another one, is calcium supplementation associated with vascular disease in kidney failure?
Yeah, so absolutely. I mean, I think that's the real mechanistic distinction. And so, you know, we know that you have to be really careful about calcium phosphate balance, and you know, there's all sorts of new mechanistic understanding about the role of FGF23 and so forth in vascular disease in renal failure, and that calcium phosphate axis is critically important in that. And renal bone disease is, of course, a complex topic in itself. But I think that the evidence suggests that, yes, that there is a signal for calcium intake and supplementation in renal failure, and the sort of cutoff as to where that becomes an issue is not well defined. But I think it's unlikely to be an issue for the majority of sort of otherwise healthy, free-living individuals. But it is certainly an issue in end-stage renal failure, where you've got perturbed calcium phosphate metabolism and PTH resistance and low, 125 dihydroxyvitamin D and inhibited 1-alpha and all of those sorts of physiological problems. So yes, absolutely a difference. But I think the reassuring thing is there's just really very little reason to see any mechanistic link in normal physiology.
And I have another question. Is there a dose relationship between calcium and MI or stroke in the trials you presented?
Yeah, and that's a really important question, because it's one of those sort of indicators of a plausible causal relationship, and really there isn't, and that has been looked at, but there's no dose response obvious where it has been looked at, and I think just that inconsistency in the calcium meta-analysis, or the first calcium vitamin D versus the WHI findings, that between baseline intake and the calcium supplements and the no personal users, as it were, that just mean that it's difficult to really present a coherent biological story in terms of baseline intake or dose of calcium.
I'm sorry, but we won't have time to answer to all your questions, and now we are going to conclude. And I would like to thank you very much for your participation in this webinar, and we hope that you enjoyed this session. We will post recordings of the webinar on the IWEF website, and you will also receive the link by email. You will be prompted to fill in a survey immediately after this webinar. We should appreciate your input and comments as we continuously try to deliver webinars that meet your needs. And last but not the least, if you have any questions, comments, please do not hesitate to send them over to webinar@iofbonehealth.org. Thanks again, Professor Harvey. Yes?
Well, thank you, Dominique, for hosting, and thank you to all of you for listening. And I wish you a very good morning or lunchtime or afternoon or evening, depending upon where you're listening from. Thank you.
And yeah, goodbye to everybody.